I'm a abdominal radiologist. I'm a professor of radiology, and my areas of expertise are genitourinary radiology. So the question is, what image-assisted strategies do we have to help in biopsying both upper and lower tract masses? So the first thing we do when we're asked to biopsy something is review the images. It sounds like a very basic concept, but we need to make sure that the radiologist, whatever we think we're biopsying, is actually what the referring doctor wants us to biopsy. Sometimes patients have multiple lesions in the kidney, and it's not always clear. So that's the first thing that we need to get straightened out. Once we're clear on what we want biopsy, we have to answer the question, can we get at the lesion, and can we get at the lesion safely? Once we've answered that, we usually come up with a plan in our mind of how best we want to image that. Now, at that point, we need to determine in advance before we schedule the biopsy if the patient is capable of staying in the position that we need for the 20 minutes for us to do a biopsy. What I'm getting at is a fair amount of renal biopsies I do prone. Not everybody can lie prone. For both breathing reasons, some patients have an ostomy, and it's very difficult for them to lie prone. So that's one thing we need to figure out. The other thing that's really important in terms of imaging strategy for biopsy is upper pole renal masses that we're biopsying can be a little tricky. If you talk to anyone who does percutaneous nephrostomies of upper pole, of upper tract collecting systems, you know, if you're off a little bit, you'll cross the pleura and cause a pneumothorax. So there's a couple things we can do from an imaging point of view to prevent that. One, we can do the entire study on expiration, where we make the lung as small as possible. Two, we can put the patient ipsilateral side down and come in from the side, because the side that's down is going to be smaller. Three, we can angle our needle from a caudal approach to a cephalad approach, and often angle the gantry of the CT machine to guide us heading up toward the lesion. Those are some of the things we can do. In general, when we're doing a renal mass biopsy, we don't ever want to cross the diaphragm, and we don't want to cross the renal hilum. We're usually going in with fairly large needles. On almost all of the biopsies I do, I use a 17 gauge outer needle, and I use an 18 gauge spring-loaded biopsy. And I usually, whenever I can, I like to do a full 3 centimeter core. So I can't cross the renal sinus because I would be coring the renal artery and the renal vein. So those are some important things that we need to keep in mind. When we're down in the pelvis, biopsying masses that are in the pelvis, if there's arteries, veins, or bowel loop in our way, oftentimes we can hydrodissect saline to sort of push either the artery and the vein away, or push the lymph node or the peritoneal deposit away. And then we can go ahead and core. Years ago, I used to do cores and FNAs on everybody. We've really moved toward just doing cores, but occasionally we can do just an FNA if a mass is literally sitting right next to the renal artery and they have just one very specific question. The patient has a history of melanoma. We just need to know if this is a metastasis. We can just do an FNA, which requires just a 23 gauge needle. And then the advantage is it's much safer, and cytopathology comes down and you get an immediate and rapid diagnosis. So after you've done your first or second pass, they say you're done and you can scoot out. So those are some of the imaging strategies that I use to biopsy masses in the kidney and in the pelvis.